First, I want to introduce myself. I'm Michel BOURIN, the new editor-in-chief of Neuroscience and Neurosurgery. I'm professor of pharmacology and psychiatry at Nantes University, France, and I'm invited professor in Craiova, Romania. Journal of Neuroscience and Neurosurgery is an international open access peer-reviewed journal aimed to disseminate the update of neurology and neuroscience. In recent times, there is an increased interest in the neurological disorder and surgery. Science Source initiated an open platform journal of neuroscience and neurosurgery, which provides complete, updated information about the developments in neurology, neuroscience, and neurosurgery. The Journal of Neuroscience and Neurosurgery has wide coverage that include, but not limited, brain injury medicine, clinical neurophysiology, epilepsy, hospice and palliative medicine, neurodevelopmental disability, neuromuscular medicine, pain medicine, and sleep medicine, neurocritical care, neurovascular neurology, stroke, behavioral neurology, child neurology, headache, multiple sclerosis, neuroimaging, neurorehabilitation, and intervention neurology, diagnosis methods, and all relative fields. Today, I want to speak about Lewy body dementia. Lewy dementia is the second most common neurodegenerative dementia after Alzheimer's disease. It is a complex disease that borrows certain symptoms of Alzheimer's disease and Parkinson's disease. So difficult to recognize or diagnose, Lewy body dementia also causes Lewy body disease. It is a form of cognitive characterized by disorder characterized by abnormal deposit of a protein called alpha-synuclein that form inside brain cells. Lewy body dementia mainly affect parts of the brain related to cognition, function, and movement. The term dementia describes the state of degradation of intellectual faculties, which eventually leads to a loss of autonomy. On some points, Lewy body dementia is approaching Alzheimer's disease or Parkinson's disease. It is distinguished by a generally more rapid development and marked deterioration of the mental faculties. Like other neurodegenerative dementia, it affects mainly the elderly. Clinical and paraclinical criteria are strongly suggestive of Lewy body dementia. Significantly more common than in other dementia and less specific complementary criteria. The existence of an evolving cognitive disorder is a necessary condition for diagnosis Lewy body dementia. Even so, it's not the only element. The cognitive profile includes both cortical and subcortical impairments associated with significant attentional deficit and marked visual, spatial, and executive dysfunction. Patients with Lewy body dementia can be differentiated from those with Alzheimer's disease because of the relative preservation of recognition and greater impairment of verbal fluency, visual perception, and performance task. Some patients may, however, have no marked memory deficit suggestive of Alzheimer's disease. The MMS does not distinguish between LBD and other dementia. Some patients with normal score, patients with hallucination have more marked visual perception dysfunction. A high number of Lewy body are involved in the anterior temporal lobe, lower lobe, and amygdala that are found in this patient at autopsy. These areas are involved in the genesis of complex visual image. Functional imaging shows a decrease of perfusion of region corresponding of the visual cortex. Visual hallucinations are associated with a greater deficit in cortical acetylcholine, and their resistance predict a better response to anticholinesterase inhibitors. The severity of the extrapyramidal syndrome is identical in LBD and Parkinson's disease, with or without dementia. Nevertheless, there is an axial predominance with greater postural instability walking and clearer anemia. Terror rest is less common. A scale like the Unified Parkinson's Disease Rating Scale may be useful in the Lewy body dementia to evaluate motor symptoms. The response to L-DOPA is less in Lewy body dementia than in uncomplicated Parkinson's disease, probably because of intrinsic striatal degeneration, or because no Parkinson's symptoms are not dopaminergic. Over 75% of the patients are still improved by the treatment. There are criteria suggestive of Lewy body disease, such as existence of paradoxical sleep disorder, increased sensitivity to neuropsics, and decrease in the dopamine transporter to functional imaging. If one or more of the evocative characteristics are present and associated with one of the most criteria, then the diagnosis of LBD should be made. A possible LBD may be suspected if one or more of these evocative criteria exist in the dementia patient, even in the absence of primary criteria. REM, rapid eye movement, REM sleep disorder, manifest themselves in often colorful and frightening dreams without muscular atony. Patients live their dreams with screen, leg movements, and significant agitation. The diagnosis can be confirmed by polysomnography. The increased sensitivity to neuropsics is strongly suggestive of an LBD, but in this absence does not exclude the diagnosis, since 50% of the patients who receive neuropsics, atypical or not, do have intolerance. Functional imaging of the dopamine transporter define the integrity of the nigrostriatal dopaminergic system and has a diagnostic implication in the face of a tremor of uncertain etiology. Thank you very much for your attention.